Okay, ladies and gentlemen, it is noon. Welcome to our webinar on increasing access to medication-assisted treatment in the criminal justice system. It's my pleasure to welcome you to this webinar series. I'm also grateful to have the support of Mallinckrodt in working on these criminal justice initiative. They've been terrific partners, and they've provided us with the resources to conduct these webinars and certainly to work with our associates at the Legal Action Center as well. As I mentioned during my brief introduction a few minutes ago, I'll serve as the first speaker and moderator for this event, and then introduce Paul Samuels. And then following Paul's presentation, I'll introduce Linda Hurley. The importance of criminal justice is trying to get the individual treated in the right place. We've had a number of increasing successes, and one of those will be presented by Ms. Hurley herself, who's been a real visionary in creating an OTP in the Rhode Island Correctional Facility, the first of its kind in Rhode Island. I'm happy to say this builds on the long-term success of the Rikers Island Keep program in New York, which opened in the mid-1980s. It builds on other systems of care, whether it's the Philadelphia jail, Baltimore jail, and a number of jail facilities offering treatment in the United States. Keep in mind that most of the access to medication-assisted treatment has been provided by OTPs working with a correction facility and then arranging to have medication taken to the facility to be dispensed by the medical personnel. Now, I can tell you that AATOD has now been working with increasing partners in criminal justice, and I will get to that when I talk about our leading initiatives in program policy. This is one of the big ones because the vision here is to have medication-assisted treatment in correctional settings, to have the inmate inducted into a medication, whether it's methadone, buprenorphine, or injectable, naloxone, naltrexone. Either way, what we're trying to do is have the patient inducted in the correctional setting with a warm handoff upon discharge so they can get into an OTP or a dated 2000 practice if in fact the patient was using buprenorphine. So with that, let's go through the slides, and I have the next one, please. And this is the map of the OTPs in the United States. There are approximately 1,700 OTPs as certified and accredited through SAMHSA. The number has been increasing in recent years. Wyoming, sadly, is still the only state without any OTP. I don't think they have any plans to open an OTP. And I can tell you that we think there's about 450,000 patients in treatment at any point in time. We will be beginning work under the Opioid Response Networking Initiative to work with NASDAD, which will be our policy partner on this, and that's the National Association of State Alcohol and Drug Abuse Directors, to really form a clear census of patients in treatment in the United States. Frankly, I think it's a greater number than 450,000 patients, but the census that we will coordinate with NASDAD will really be the defining difference. So I'm very grateful to the American Academy of Addiction Psychiatry and the Opioid Response Network for providing the funding opportunity to get this finally done in an updated version. May I have the next slide, please? So we've been involved at AATOD with this initiative for a very long time. This is an article that I wrote for the American Jails magazine 20 years ago. And you can see that if you can read the date. It was 20 years ago in May that I wrote this. And the graphics are courtesy of the creative editors of the American Jails magazine. It's sort of apropos that we're in the Halloween season to see the sort of dark green against purple colors. Just to be clear, there's never been a methadone product that had a purple diskette. So to go to the slide, this is after this jail slide. The next is an updated version. This is a fact sheet that I had wrote at SAMHSA's behest. It is available in the policy section of our website. Even though I am the author of this, this went through a lot of different editorial reviews. It provides a very fair, I think, reasonable approach in how people can understand how medications are used, the difference between the three federally approved medications, and it debunks some of the myths around methadone treatment for sure. So it's on our website. If you haven't read it, I suggest you do. It's a nice, quick presentation of how these medications have been used, the research that supports how these medications have been used as well. May I have the next slide, please? This represents what I perceive to be a breakthrough document. This was published by the National Commission on Correctional Healthcare and the National Sheriff's Association. It had the support from our Federal Department of Justice. As you can see from the title, it's Jail-Based Medication-Assisted Treatment, Practices, Guidelines, and Resources. This was released October 2018. I happened to be speaking at their national conference in Las Vegas when this was published and released. It represents a great document, and it's a groundbreaking document. So we're working closely with the NCCHC and Sheriff's Association, in addition to the American Correctional Association, the drug court, both at the national level and at state levels. And I have to tell you that this networking is increasing, and this is going to be another major project under an open opioid response networking initiative. And again, I'm grateful to have this opportunity. But this is a breakthrough document, ladies and gentlemen. It's referenced on our site. If you can't get it, you write me and I will get it to you. And my information appears at the end of this presentation. Next slide, please. So you're going to hear from Linda Hurley, but I'm showing this as a sort of reference slide. This is another important breakthrough. Linda Hurley will talk about the success of this program, how this program was developed, the success in post-release decreased recidivism and post-release decreased mortality. It's a remarkable program. And I know that I've probably sent more people Linda's way than she would care to, but you have this model program, and there is composite models also in the state of Connecticut. And Kathleen Mora is in charge of that in working with the Connecticut Department of Corrections. They too have found similar outcomes. Next slide, please. So I'm going to go quickly through this major policy initiatives, but you should know them because it provides a context for what we're doing. The implementation of the Medicare reimbursement rate for OTPs began January 1, 2020. I sent a Medicare enrollment impact report to CMS Medicare recently, a couple of months back. At that time, there were about 800 OTPs which were enrolled, and now enrollment is picked up again now that the system is adjusted to COVID-19 treatment realities. The promulgation of the DEA mobile van regulations is pending. The DEA issued a federal regulatory notice on this recently. They've gotten comments from various partners in the field, including AATOD. In a recent discussion, it should be at the Office of Management and Budget, OMB, which is the stage before it can get released in final form. Once that happens, we will use that and advise our colleagues at the states, the providers, that they can develop mobile vans in their respective states. Certainly, we'll work with the Department of Agriculture when these vans are used in rural areas, which are defined as 50,000 population or less. SAMHSA money can be used through the states, alcohol and drug abuse authorities, if the vans can be used through OTPs and in suburban and urban areas, and they exist. There are not a lot of mobile vans out there, but now this will be a new opportunity, and we're certainly going to work with the DEA, with SAMHSA, with the SODAs and NASADAD, and the Department of Agriculture and other partners to make this happen. We think there are two applications for the DEA mobile vans. One is on this topic, so that the OTP could dispatch a van into a correctional facility compound, again with agreement with the program, with the state alcohol and drug abuse authority, and with the correctional facility itself and the State Department of Corrections. And there's another one, which I mentioned, which is expanding the use of such vans, especially in rural, suburban, and underserved communities. I've talked about the Department of Agriculture funding. I'll just say that the DOA also has funding so that they could give money to a program if they want to rehabilitate a building and turn it into a satellite medication unit. Then the implementation of new Medicaid rates, we are working on this right now since Congress and the Support Act required that the remaining states that did not have Medicaid reimbursement when OTPs were treating Medicaid eligible patients must do so by this month. I can say that North Dakota, Montana has implemented such rates, and I understand this has also happened or is happening in Louisiana and is about to happen in Oklahoma. I'm currently working with the other states like Utah, Kansas, Arkansas, Tennessee, Mississippi to work with their state agencies. I've been working closely with CMS Medicaid, and they have been very helpful as well. Next slide, please. So the impact of COVID-19 is something we've been working on. I sent an impact report over to SAMHSA and the federal agencies, which is jurisdiction in this area. With the help of Angelina, we actually published and released a video blog, and that also has the COVID-19 report. So you can go to our website to access that. And again, I thank Angelina for her work on that. Absolutely, there's been an expanded use of telehealth, telecommunication. What we've learned, which is contained in the impact report, is that more stable patients seem to be good with telehealth, telecommunication, where the more unstable patients seem to prefer face-to-face counseling discussions. We have learned that greater flexibility of medication take-home has been able to give patients more opportunities for take-home and less need to come to the program itself. Contrary to what a number of us thought, there was less overdose. We have not received reports of mortality related to providing more medication take-home. There has been misuse reported. There has been an accelerated consumption of some take-home medication. So I don't want to give you the sense that this is perfect. And the toxicology testing results are showing that there was heroin and fentanyl in urine samples, toxicology samples, or saliva samples, depending on the testing method. And the access to personal protective equipment is stable for now. It was a nightmare, I mean an absolute nightmare, between March and May of 2020. I'm grateful that SAMHSA and ONDCP, the White House Office of National Drug Control Policy, provided critical letters that designated the OTPs as essential medical services, and that triggered the big distribution houses, whether it's Cardinal, McKesson, or Clorox itself, to provide personal protective equipment and cleansing equipment as well. So we're stable now, but it was very difficult at that time. Finally, I'm happy to report, and surprising to me, that the incidence of infection rates among patients and staff was comparatively low relative to the other general population. That's changing now clearly as we go through surges in different states, and we're working with Hopkins research team that will give us more information as well. Next slide, please. We are convening a basically product conference. It's going to be in April 10th through the 14th at the beautiful Venetian Hotel in Las Vegas. This is called a classic hybrid conference model. It's with in-person participation and virtual participation. I'm grateful for Carleen Maxwell Taylor and our colleagues at Tally Management as we develop this. I can tell you that the workshop committee has now identified its 33 workshops. Our awards committee is now identifying the award recipients, and the other partner committees are working to get ready, including the plenary session. It's going to be another very well organized conference with lots of great information. So I urge you to consider registering. You can go to our website to get further information. Next slide, please. This is my contact information if you need it. I'm happy to respond. Again, if you need things that are discussed in this presentation and webinar, we're happy to provide it. So for me, I'll close up by saying thank you for joining us. It's a great pleasure to give you this information. And the next two speakers really have Absolutely terrific and rich information. So it's my pleasure to introduce our next speaker, Paul Samuels, the President, Executive Director of the Legal Action Center, both in New York and Washington, D.C. I have tremendous respect for this man. I've known him for over 35 years. I respect his associates at the Legal Action Center. We work on a host of policy issues, and actually we're co-located with the Legal Action Center in New York. This gives you a real clear idea of how valuable they are as policy partners. They've assisted us in guiding on confidentiality-related decisions, issues around prescription drug monitoring programs, and certainly this issue in criminal justice. They've also done terrific work in trying to get Medicaid reimbursement for individuals behind the walls so that they can get treatment, not just for substance use disorder or alcohol abuse disorder, but also for general health care too. They are terrific, and with that, I can tell you this man has a lot of experience, and I don't know if he'll reference it, but they did a groundbreaking report in 2011 on the constitutional realities around providing access to MAT in the correctional setting. Sally Friedman was the author of that, another terrific and really brilliant attorney at the Legal Action Center. So again, Paul, thank you for appearing, and thank you for what you're doing to help us out.
Thank you very much, Mark. Really appreciate that very nice introduction, and we are very honored and pleased to be here. We really treasure our collaboration with AATOD, and it's terrific to be with all of you out there in virtual land. I'm going to bring up my slide presentation. And my presentation is about the continuum of care and the role of criminal justice in treatment, and specifically focusing on medication treatment for opioid use disorders. For those of you not familiar with the Legal Action Center, we've been around for quite a while. We're 47 years old. We're a nonprofit national law and policy organization. We do policy and legal advocacy to expand opportunities, end discrimination, and protect the privacy of people who have substance use and or mental disorders and other chronic illnesses. Really what we're dealing with is a horrific problem. The scope of the problem is enormous. I'm just going to start with a few statistics that really, unfortunately, make all too clear just what an enormous problem we're dealing with in the criminal justice system. Incarcerated individuals are 7 times more likely than the general population to experience substance use and mental disorders and other chronic illnesses. There are more people in the criminal legal system with substance use disorders than there are people in treatment. In fact, nearly 3 times as many. Looking at some national statistics from the Bureau of Justice Statistics, between half and 3/4 of incarcerated people have some type of addiction problem, and more than half have a mental illness. The Marshall Project has concluded that illness for illness, the incarcerated population, individuals who are incarcerated, are the sickest people in our country. There is also an enormous, as we all know all too well, and has really been emphasized in recent months, a racial and racist element and tremendous structural racism in the criminal legal system. Most of the people incarcerated, a very vastly disproportionate number, are people of color. They have, in fact, higher rates at all levels of the criminal legal system, including arrest, prosecution, and conviction, as well as incarceration. African-American adults are 5.9 times as likely to be incarcerated as whites, and Latinx adults 3.1 times as likely to be incarcerated as white adults. To take a look at one state snapshot, the state where I live, although when you look at your statistics around the country and the states that you live, I think unfortunately you'll find similar very horrifying statistics. The New York State Department of Corrections and Community Supervision, which is the agency that runs both the state prisons as well as parole, has found that 83% of incarcerated individuals need substance use disorder treatment upon release. A really staggering statistic. Looking at New York City, 40% of individuals in New York City jails have a mental illness, even as the total number of incarcerated individuals has decreased. So what you can see from that is that the percentage of the people in New York City jails with mental illness has risen drastically and is at an unconscionably high level. The stakes could not be higher. The lack of treatment access post-incarceration is costly, contributes to emergency room use, homelessness, and lost productivity. Most important of all, the lack of healthcare interventions cost lives. When people come out of jail or prison, there is a 12-fold increase in the risk of death during the first 2 weeks post-release from incarceration, 12 times. And looking at it from a different lens, individuals who are leaving prisons and jails are 130 times more likely than the average person to die of an overdose in that time period. And this is in the midst of the worst overdose epidemic in our country. For people who are coming out of incarceration, their risk of overdose death is astronomically higher even than the general population, which itself is suffering from a huge epidemic of overdose and overdose death. When I go back for a second and show you, so the title of this slide is "The Stakes Could Not Be Higher." This is a slide that I presented at the AATOD conference last year. And now COVID-19 has raised those stakes even higher. It is estimated that over 100,000 people in carceral settings in jails and prisons nationwide have become infected with COVID-19. A recent analysis published in JAMA found that from March 31st to June 6th, COVID-19 cases in the United States federal and state prisons were 5.5 times higher and death rates 3 times higher than in the general population. And to give a stark illustration of how much more dangerous it is to be incarcerated and at risk for COVID, even more than in the general population, which we know is also at great risk. Currently, every one of the country's 14 largest known clusters of COVID-19 cases are correctional facilities. The hottest spots in the country are our jails and prisons. So COVID-19 is exacerbating the racial and health disparities, which were already very substantial and now have made them even worse. So among other things, it's critically important to keep as many people as possible out of incarceration in this very dangerous climate. To look at it from the positive side, we have a huge opportunity. While the quality of care inside prisons and jails needs improvement, I'm going to focus on reentry because reentry into the community is consistently the key point of systemic breakdown, but it also presents the greatest opportunity for major reforms. As we'll discuss, there are many opportunities to make the situation much better and to provide the kinds of care and services that people need to successfully reenter from society as they leave incarceration, to address their substance use, mental health, and any other healthcare needs, and then live healthy and productive lives. First, I want to set the legal framework. As Mark mentioned, 9 years ago, the Legal Action Center developed and disseminated a legal analysis, which found that prohibiting medications for opioid use disorders by states and local governments, including courts and employers, can be illegal under the Americans with Disabilities Act. And specifically, our memo concluded that courts that prohibit medications for opioid use disorder or set arbitrary dose or duration limits can violate the Americans with Disabilities Act. Substance use disorder is a covered disability under the ADA, and denying people access to life-saving care for that illness is a violation of the ADA wherever that occurs. by state action, and that includes courts and other parts, jails and prisons and other parts of the criminal legal system. After Legal Action Center, a number of years after Legal Action Center issued this legal opinion, the U.S. Department of Justice agreed in a letter to the New York State Attorney General. And in this slide presentation, I've listed a number of, I've included a number of links for those of you who want further information. And as you also see, as I'll go through this, there's more information on the slides that I will be presenting orally. So we wanted to have you have the detail available. Our legal analysis also find that there is a U.S. constitutional, that under the U.S. constitutional right to substantive due process, which prevents governments from interfering in fundamental rights to control one's own medical care, policies that prohibit access to MOUD can also be unconstitutional. So this is not a legal opinion that's just theoretical. There are now at least 8 cases across the country that have successfully challenged denial of medications for opioid use disorder in corrections. And I list them here and on the next slide. You'll see that there are 2 in Massachusetts, there are 2 in Maine, 1 in Washington State, and 3 at the federal level in the Federal Bureau of Prisons. Generally, for each of these cases, and I'm not going to, as I said, go through each in detail. We don't have time, but I do want to summarize what these cases did. And generally, each of the defendants in these cases had a medications for opioid use disorder policy that included the following elements. MOUD was prohibited in the jails and prisons. Individuals entering custody who were on MOUD were forced to go through withdrawal, but they had exceptions for pregnant women. And then for the plaintiffs, those who brought the lawsuits, generally, all of them had the following experiences. They were struggling to find treatments that worked. They had finally achieved active recovery after being prescribed MOUD. They were facing or had already experienced forced withdrawal upon entering the relevant facilities to serve their sentences. They were all fearing the physical and psychological pain of forced withdrawal, and they were all fearing the consequences of withdrawal post-release, including the heightened risk for relapse, overdose, and death, which, as you know, I discussed just a few minutes ago, is truly terrifying. There was also one court ruling on the Constitution that found that the plaintiffs likely demonstrated an 8th Amendment violation for cruel and unusual punishment. And in this case, for the plaintiff, the only treatment that had worked was methadone maintenance treatment. The jail knew of the plaintiff's needs for methadone, but based on its policies of denying everyone MOUD, it would be deliberately indifferent to the plaintiff's needs, meaning that it would not provide that care. Other medication is not interchangeable with methadone, and the plaintiff's doctor had prescribed methadone. Looking at it from the defendant's side in each of these cases for the Americans with Disabilities Act, defendants argued that plaintiffs are not excluded from medical services, they just want different services, and that this disagreement is not discrimination. But the courts found otherwise, rejected those arguments, and found that there is no justification for denial because there are a number of ways to safely provide methadone in buprenorphine. Since the jail provided methadone to an incarcerated pregnant woman without issue, it was clear that the jail was capable of making the accommodation. It was also found in that case that jail medical staff had no interest in learning about MOUD. And then, as I mentioned, there were successful rulings under the Americans with Disabilities Act in many cases. And I'm going to, in the interest of time, just skip ahead and show you here, though, that there is more information here and more information available from us for those of you who would like it. So what has been the impact of these decisions? Federal, state, and local corrections decision makers are now on notice. There is greater momentum for policy and practice change. There are recent legislative and executive activity at the state, local, and federal levels, additional focus on how to finance care behind the walls. There's potential for greater engagement with treatment experts in the community and possible implications for other systems, including healthcare, child welfare. And also a little bit later, I'm going to talk about a very important new initiative for the last few years, from the U.S. Department of Justice. In fact, so I'm going to skip right to that now. So in the wake of the opioid epidemic, and utilizing, as I mentioned before, the legal opinion that Legal Action Center pioneered, as well as others who then joined in, the Department of Justice has found in a number of different settings, not just in criminal justice system, that it is illegal to deny access to medications for opioid use disorder. There was a case, and I'll just, again, not go through the details, but just highlight the various settings in which the Department of Justice has found that it's illegal to deny access to MOUD, where that is the appropriate care. There was one case that found it in a health and rehabilitation center, another in a primary and specialty care facility, another in skilled nursing facilities, another where in a hospital setting where a patient needed a lung transplant, but was denied because of their treatment for MOUD. Also for child welfare, the Department of Justice wrote a letter to the New York Attorney General explaining that courts that prohibit MOUD as a condition of child custody or visitation may be discriminating in violation of the Americans with Disabilities Act. There's also a case in West Virginia against the agency there that was discriminating against people with disabilities in child placement and other services. So for the last part of my presentation, I want to concentrate on what are the opportunities for making all this better. As we've just seen, there is now a very strong legal basis as well as medical basis for requiring that everyone with an opioid use disorder who wants and needs medications for opioid use disorder needs to be able to get them, that access must be guaranteed. So sort of threshold recommendation for the criminal legal system is that everyone who needs MOUD should be able to receive high quality SUD care, including all forms of MOUD, both during incarceration and as they re-enter the community. In order to implement that, we need to develop policies and practices across the country. And this is mostly, as we know, that since most of what happens in the state, in the criminal justice system happens at the state and local level, that's where the action is. So states and localities need to develop policies and practices that support uninterrupted Medicaid coverage as people move throughout the criminal justice system and between the criminal justice system and the community. For those states that have expanded Medicaid, a great majority of the people who are incarcerated as well as elsewhere in the criminal legal system are eligible for the Medicaid expansion. And there the federal government pays for 90% of the care. So it's a huge financial incentive as well as healthcare and justice incentive for states and localities to utilize Medicaid and provide the kind of care utilizing Medicaid that people need in the criminal legal system. It's also critically important that we promote diversion to healthcare, including SUD care, whenever possible and as early as possible, including pre-charge. And in this current climate, with a greater focus on the often inability of the criminal justice system to effectively address people with healthcare issues, especially where the behavior involved concerns substance use disorders and/or mental health issues, we need to have a much greater focus on intervening with people even before they are arrested. It's very often a healthcare intervention rather than a law enforcement intervention is most appropriate in all senses, including preserving public safety, as well as getting people's healthcare needs addressed, and then of course, saving a huge amount of money. We need to also ensure that judges, probation and parole officers, and other law enforcement officials allow people under their supervision to receive appropriate SUD care, including MOUD. As we went through those legal cases that have been decided, it's not just that there have been violations of the law that were caught in these cases, but unfortunately, it indicates that there is still a widespread resistance to utilizing what is the gold standard for opioid use disorder care, which is medications. And that needs to be overcome, both from a health perspective, but also from a public safety perspective, and increasingly ensuring that people's legal rights are upheld. It's also critical to utilize peers to assist in enrollment, provide navigation, and increase health literacy. There has been recent legislative and executive activity at the state, local, and federal levels. Work is happening around the country, and there's a continued need to focus on improving coverage for and access to care, including MOUD in the community, to maintain strong patient privacy protections, and to eliminate policies facing people with SUD histories. I also want to tell you about what continues to be an exciting potential public policy reform that is under consideration in Congress right now and at the regulatory level at CMS. And that is that right now, under current Medicaid law, Medicaid cannot be used for any health care inside the walls. And that's even to cover care that might be provided from an outside provider of substance use disorder, mental health care, who comes inside the walls to assess someone's needs, arrange for them to come out into the community to obtain the care they need, having assessed them and developing a treatment plan. It's a very exciting opportunity to try to get inside the walls, start treatment before people leave. If people need a medication for opioid disorders or other substance use disorder or mental health issue, to begin that medication before the person leaves, and then ensure their continued care as they come out. But what we have seen is that the lack of Medicaid coverage for any care inside the walls is a huge barrier to being able to provide that care. So New York State and Utah and other states have been talking to CMS about the possibility of obtaining a Section 1115 waiver of what is called the Medicaid inmate exclusion in order to be able to utilize Medicaid funds in the last 30 days of incarceration for those kinds of assessment, case planning, beginning of medication induction, and the like. And also recently, a proposal has been introduced in a number of the bills in Congress called the Federal Medicaid Reentry Act, which would put that into law rather than to have to obtain a waiver. So important possible development to keep our eye on. And I think that at this point, I'll just conclude by saying that there has never been greater momentum for policy and practice change. We have it as a question mark in the slide, but I want to change that to an exclamation point. There's tremendous opportunity to make great progress. And as we've seen, there are a lot more tools at our disposal now, including legal basis for requiring that MOUD be made available throughout the criminal justice system whenever that would be appropriate. Really appreciate, Mark, the opportunity to present, and I'll turn it back to you.
Okay, well, thank you, Paul. It was an excellent presentation. It's filled with information. I'll answer one question that was put to us during the time of your presentation. Then I'm going to ask you to quickly respond to one question before I introduce Linda. First of all, Paul presented a number of opportunities, and you can go to the website. And once, as I said, this recording is available, Angelina will keep you informed, and obviously all of the presentations themselves will be there with you, so you can follow them through the audio. The question came in of how many states are using mobile vans. I can say that I know that they exist in Massachusetts, in Maryland, and in Washington State. They've been there for many years. I don't think there are vans operating in rural or frontier communities at the present time. This is why we've been working with the DEA to get their regulations out and published, as I mentioned during my introductory remarks. So we hope that this will expand as an opportunity, and as Paul has referenced it, and what the work the Legal Action Center is doing with its policy partners on Medicaid, with CMS and the states as well. So we think that, the model of having this reimbursed is critical. And then, as Paul talked about, having the education provided too. But the questions that have come in, we'll start with: correction system did not support MOUD. Is that still the same? And if so, why is that? And this is, I think, specifically referencing the Texas correctional system.
Yeah, so unfortunately, we're still at the point where most correctional systems are not providing MOUD. As I discussed, there's both, tremendous public policy reasons to provide it, as well as now, probably a legal requirement to do it. So our challenge going forward will be, as I talked about a little bit, to educate people within corrections and elsewhere in law enforcement about the efficacy of MOUD treatment, but also that there are effective and safe ways to provide it inside the walls, and that in fact, for people who need it, that is increasingly clearly a legal requirement. But it's going to take a lot of education and advocacy by all of us who care about these issues to go from what a reality which is now this is happening in a few places to where this is happening everywhere.
And that's clearly true. Another question quickly that came in from Sue Martin in New York is that what we know is that in New York State, there's the issue that state officials are often unwilling to consider a van to be a clinic as described by the Controlled Substances Act. I can answer that. I think that what happens now with the DEA releasing the final regulation on vans, you will have a coordinated effort with OASAS in New York and SAMHSA clearly, and the DEA, because what the DEA has done remarkably is lessen the regulatory difficulty in setting up a van, because now an OTP can develop a van as part of its treatment system, and that van would operate under the licensure authority of the existing OTP. Once that happens, it is completely legal for an OTP to work with a van, and the van is part of the OTP. The van is not a clinic per se. The OTP is the hub site in this regard, and look at the van as one of the spokes, which is sort of based on a Vermont hub and spoke model. See, part of what the association is doing and has done, is continuing, is expanding the footprint of the OTPs in rural and suburban areas using a number of mechanisms like satellite medication units and the van systems. And this may be a crossover question. I know it came up during Paul's presentation. Linda might address this as well now. And it was, wow, 130% more likely case for overdose deaths after prison. Why? Paul, do you want to take a quick crack at that before I introduce Linda?
Well, I think that the primary reasons are that people, when they are incarcerated, either were not using drugs, or often were using drugs, using opioids, but not at the same concentration, not the same dosage as when they are on the outside. So then when they come out, there are several things that come together to put them at great risk. One of them is the stress and fear that people have, anxiety that people have when they come out, which puts them at great risk of relapse or of increasing their drug use if they were able to use to some extent while inside. But then if they use at the same level that they were before they were incarcerated, that may more quickly lead to overdose. Now that's not coming from a clinician. That's coming from what I understand from clinicians, and I've be happy to defer beyond that to those who are more expert than I am. But that's what we have seen as the explanations and the data that we've looked at.
Yep, and that certainly is correct. So we do have more questions for you, Paul, but what we're going to do, as I said in my introductions, we're going to defer to the end so that Linda can present her information, and then we've retained the questions, so they will all be asked and answered. So now, thank you again, Paul. I know you're going to stay with us so you can respond to these questions, and we'll do the best we can to get to everybody. So as promised, I'm happy to introduce Linda Hurley, the CEO of the CODAC facilities in Rhode Island. And she's particularly, the CODAC system is the largest of the OTP systems in Rhode Island. It has benefited greatly from stable, successive leadership, beginning with Craig Stenning, going on to Mike Rizzi, and now going to Linda Hurley. We know through literature, and it's important to point out, that stable management absolutely has a favorable impact on treatment outcome. This was demonstrated during the John Ball studies. It also showed that maintaining stable staff complement of competent and trained professionals also leads to better patient retention and treatment. I can think of no better model than CODAC in dealing with these issues. They've done wonderful work in coordinating mental health care for their patients. They've developed terrific partnerships in the community to be sure that the patients truly get holistic care in a remarkably well-managed and coordinated environment. I've heard Linda make a number of presentations on this topic, especially during prior webinars and when I was speaking up in Rhode Island as well last year, all pre-COVID-19. And her work in Rhode Island has been remarkable. She will talk to you about how this program was developed. CODAC was delivering medication to the correctional system. That served as a prelude to implementing the first OTP in a correctional system in that state. She has remarkable findings, and I will not blunt the force of what she will say, because it's important that you understand this model and how effectively it's been used. So I turn this over to Linda for what I know is going to be an extremely informative presentation. And thank you for doing this, Linda.
Thank you, Mark. Well, following you, following Paul, and following that introduction, I have to say I'm a little bit intimidated, but thank you very much. And thank you for the opportunity. Clearly, everyone involved in this project is remarkably committed. You will note on the first slide here, Dr. Rosemary Martin's name is there as well, because CODAC partnered with Brown University in order to make sure that our outcomes, our metrics were clear, and that our outcomes, the results of the program, and everything that we publish is of the highest integrity. And she has done an incredible job of the entire data collection and data analytic and evaluation process. And that's what you will see in the second half of this presentation. I just wanted to make sure, because my dear friends, I am not a researcher, and I'm very anecdotal. It would never work. Advance, please, Angelina. So hopefully what you will leave here with in the next 18 minutes or so is a brief understanding of how we implemented the program. And most importantly, what is the program? What are the principles that gave us the outcomes that show that it was an effective and efficient project? Next, please. So Mark had referenced earlier, prior to 1994, in Rhode Island at least, and in most of New England, most individuals weren't medicated upon commitment if they had been in treatment prior to incarceration. And so it was rather harsh. We used to have individuals who were in care in the community come to us and say, I need to be on a withdrawal protocol. I'm going to court next week, and I know I'm going to be incarcerated. I don't want to be that sick. So I'd rather be sick outside than inside. I mean, really, really harsh decisions that people who were fighting for the recovery had to make. As the years went on, most of you are probably aware that I guess 1994 was that pregnant pregnant individuals were maintained until they gave birth. And then there was a withdrawal protocol. And those that had a diagnosis of HIV were. Next slide, please. Medicated while incarcerated. Next slide, please. So let's fast forward from that harsh place, 94 until 2015. Suboxone has been introduced in the country early 2000s. Data wave docs are providing treatment in the community. So a great deal happens. We start to see the medical proclivity to help people with pain, all the right reasons, but ultimately contributed significantly to the opioid epidemic. And then in Rhode Island in 2015, we had the third highest rate of overdose death in the country. So our governor created a task force, and through that initiative, high-risk populations were identified. And the high-risk population of those recently incarcerated, as Paul and Mark discussed, was off the map. It was 21 to 25%. The population recently incarcerated and then released had a 21 to 25% higher rate of overdose, So our Department of Corrections received $2 million to support the strategic plan, which was actually a further development of the initiative that CODAC had with the Rhode Island Department of Corrections. Next slide, please. So that is really, we had a strong budgetary support. So we can go to the next slide. Again, I'm going to be speaking quickly. I tried to put a lot of information in here for you. One of the things that I included here is I've given this presentation at this point all over the country because, as Paul said, primarily because of legal precedents at this point. All jails and prison systems are looking to do this. So here are poll questions that I've asked different correctional staff. And I think it's important to go through this slide a little bit because it gives you an idea of the challenges that we all face when we try to bring something, a concept, a medicine, a science, a belief that is foreign to the existing culture. And so what medication do you believe is most effective, particularly with jail and prison staff? Naltrexone at 80%. What medication do you believe is the choice for patients who are incarcerated? For the same staff, they believe that the inmates, if you will, or our patients would choose methadone, but naltrexone would do the trick. And the answer here is in Rhode Island, when individuals have the choice, about 60% choose methadone, about 40 buprenorphine, and somewhere 0.2, 0.08 choose naltrexone. So, and then again, when you look at what is most accepted by correctional staff, it is naltrexone. It's the depot naltrexone because of what is believed, and we will show you later, what is believed to be undivertible. Okay, next, please. So the principal elements of the comprehensive MAT program in Rhode Island, number one, that all FDA approved medications are available and they are provided, and it is based on patient choice with the advice and support of the provider, the medical provider. Patient choice, because what we want to have happen is the patient chooses their medicine, they utilize their medicine, and when they leave and go into the community, they are using the medicine that they have the most confidence in. And that is truly critical for, we know that, for the efficacy of any medication. To then, the medication is then available to anyone who needs it. So there are three primary populations: the population that has been stabilized or on medication in the community, we simply continue them once they enter the correctional system. Those who come in withdrawal, we really do try to induct them within 24 hours. I'll tell you how that happens. And those who are about to be released, and I want to expand a little bit on what Paul said, because those individuals that have been sentenced and they've been in prison for, say, 3 years. You know, Linda Hurley's been in for 3 years. And let's just say I've never used inside. And I know I'm going to be released 2.5 months. So my brother starts calling and says, we can't wait to see you. Where are we going to have a party? And then I start to have dreams. I haven't had treatment, right? So this chronic relapsing disease of the brain, okay, is still cooking. I don't have physical dependence anymore, but I still have cravings now, and I'm having dreams, etc. And I am 130 times more at risk, or a 12% higher rate of risk. So in this model, an individual who is about to be released, we ask that they ask at least 30 days prior to release, as close as possible, can get stabilized on the medication of their choice before release. And we have a lot of pushback about that because there is not a great deal of understanding out there. And I can understand why, the difference between physical dependence and tolerance and the brain change that comes with opioid use disorder. The third principle is that there is a co-located OTP, CODAC OTP, right on site on the campus in the busiest building where we provide the most medication at the Rhode Island Department of Corrections. It's fully staffed DEA pharmacy. And the fourth pillar, and I call them pillars, the principles, but is truly intensive, seamless discharge planning and reentry services. So that the way that this happens is discharge planning starts at commitment. And what we've seen is that the longer individuals are incarcerated and in treatment and getting stable on their medication and receiving services, the longer they're there, the more likely it is that they will continue services in the community. So we want to catch them early, start discharge planning early. And we don't have time in this particular presentation, but in Rhode Island, there is an initiative that CODAC has partnered with the Rhode Island Department, the Rhode Island State Police. And we actually provide transportation from discharge to treatment or someone's home. Next slide, please. The co-location is really important because we talk about different methods by which to get the medicine to the correctional facility. And what's important about having it be right there is that you get a real-time response to dose changes and you shorten the time between commitment and diagnosis and then receiving the medication. Next slide, please. Okay. I've included some slides here. I'll go through them quickly, but I've included some slides that can help you if you are speaking to individuals who may have caution about this or not understanding. So these are just bullets that I've used with judges, with police departments, with security, the uniformed staff, correctional folks. So number one, the AMA definition. People don't usually argue with the AMA. When they hear that it's a chronic relapsing disease of the brain, the doctors say so. Often that opens the door a little bit. The disease occurs as a progression, and the rate of which this progression is highly individual. So one size never fits all with anybody's recovery and healing. Highly complex, and then give examples of all the facets of life that are impacted by this. And understanding that effective treatment requires highly skilled providers and experts. And that because I'm just going to throw this in, I am editorializing. I think in our we're very well-intentioned effort to increase access to care, we have diluted the complexity of the disease. And what we need to do is not dilute the competency that's needed to treat it. We need to create more competency. End of editorial. We know that often the efficacy of medicines and other treatment is positively impacted by patient perspective. We covered that. Next slide, please. I included this slide again because I'm preaching to the choir right now, but you're welcome to use this, and I've had remarkable reception to it. So this is a way to explain why patient choice in medication, along with, of course, clinical analysis and diagnosis, is important. So if I have used on the weekend for the first time and I liked it, and then I didn't use again for 2 weeks, the imprint on my brain is like those footprints, and the tide comes in, the tide goes out, and there hasn't been any permanent change. If I use a couple weekends in a row, and this has happened, and suddenly one Monday I wake up and I'm feeling a little bit sick. Okay, I've created what looks like a goat path here on the top right. There is a path in the brain. There's been some change that it says, wow, this is cool. I like it. I need it. Okay. So clearly the footprints don't need medication, and the goat path might not need medication. It really, because it's so highly individual. But the majority of the time, maybe a short-term withdrawal protocol with buprenorphine may work for the top right quadrant of use. If I continue to use, and then I start to continue to use so I don't get sick, but I manage, then I've developed this highway. I have a deep foundation. There's change going on in the brain, bottom left, right? This could be any number of this could be a withdrawal protocol. This could be short-term maintenance, long-term maintenance. It also could be no medication at all. We know that there's many ways, but about 80% of the time, bottom left quadrant, country road with a strong foundation, you're going to need some help. Now here we have a 6-lane, 5-lane highway. By now my brain knows what it likes, knows what it needs, and what it needs has changed. And this is where medication is remarkably important. So if I've been using for 20 years, I get incarcerated, I go to jail, and someone says to me, well, the only thing we have for you here is naltrexone. It'll help with your cravings. If once you understand what that means, that is not going to be the most effective medication for that individual. I've actually had people I've had folks write me letters about this slide and the way that it helps them understand that they didn't know before. Because really anyone that is uninitiated to this field loves a depot, naltrexone, or anything that isn't injectable for over the course of a month because of the diversion issues. Next slide, please. So here we have the medication. I guess to back up a minute, what we have is you now understand what the program looks like. Anyone that needs it as soon as possible upon commitment. Patient choice with, of course, with the provider's approval and analysis, and seamless reentry. That's it. That is the program. So how do you take these 4 components? What does it look like within a system? So these are the medicines that are most commonly chosen. Methadone is the blue line, buprenorphine is the purple line, and naltrexone are the little red tips. And again, we don't have a lot of bias. As Dr. Clark always says, we're all pretty much medication agnostic. I've been told that because CODAC is recognized as the OTP clinic, that there is a bias because we want people to be utilizing methadone as their medicine. And this is we are not consciously biased in this. Next slide, please. Okay. So the next, I believe, 5 slides, I'm going to just ask Angelina to just go through them quickly here. Next one. Next. 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 And next. And one more, we'll go through the co-occurring. These are there for your reference. when you're, next one, please. As you can see, I believe this is the last one. As you can see, they speak to medical comorbidities, they speak to mental health co-occurring disorders, and it speaks to polysubstance disorders because we see almost zero single substance use at this point. As a matter of fact, in Rhode Island right now, I think we are at 80% fentanyl on all overdoses from a medical examiner's perspective. 80% has fentanyl. Next slide, please. And the next slide. Boy, I gave you a lot of references. Okay, summary of needs. So here we are. We're, if you're speaking to someone, this is the disease. This is what we need to do to make it be effective for folks. You need treatment. You have to understand that it's a complex polysubstance disorder, that it requires all medications because it's unique to the individual. People need to be able to understand that access to all the multiple comorbidities exhibit need to be in place. And there needs to be a system to address social determinants in the reentry process. Next slide, please. Not a small order. Next slide. We need access to all levels of care. Can you back up? I'm sorry, Angelina. And pain management needs to be included, and we all know that this doesn't happen in a vacuum, so we need to understand every piece that's being impacted in our community so that we can support the individual, allow for that healing and the community healing. Next, please. So these are all the principles that go into place to make the system work. Services, so that's the big picture. The treatment inside the DOC to do that is counseling, med management, discharge planning, and the aftercare follow-up. It's worth having these slides in more than once. We've already talked about the importance of them, but it's important to, sorry, that just popped up there. It's really important to emphasize. Even now, we're doing, we actually did continued groups through COVID, but I'll speak to that a little bit at the end. Next, please. Just a different way of looking at it. So through these four components of care, next slide, we touch on every piece of what is needed in order for an individual to effectively heal from the disease. The point being with all of this is that we know this is what's needed in the community. The individual is no different once incarcerated, so that all the needs remain the same. Every piece of this remains the same for people to be successful, if you will, or meet their goals in recovery. Next, please. There's often a bias that it's not needed because individuals are in this carceral space. So the populations we serve, the blue is those that continue from the community. The new inductions are 40% and the pre-release are 5%. And I have a slide that's really interesting about that. I find it so exciting. Continue, please. Okay. Again, bullets for you to use. Next slide, please. This just talks a little bit about how we are different. I mean, Rhode Island basically is the size of a peanut, shaped like a peanut. We have a little over 1 million people. We only have 13,000 commitments per year. We also provide care at a jail system in Western Massachusetts, and it's a small jail system in Mass, and they have more than we have in the whole state. So we can go to the next, please. Okay. So 12% of the sentenced inmates residing in Rhode Island indicated opioid use disorder. Can you continue, please? So now you know the population. Now you know the population and what the program looks like. Now we're looking at if you happen to be in the correctional system as an administrator or a provider of care, what's important to look for in selecting your vendor and community partners. Because a lot of the pushback I've received as we have been going around the country is based on unhappy, unproductive experiences with their vendors, so to speak, in the community. So you need a vendor who's flexible, demonstrated capacity, understands correctional mission, okay, and has an ability to integrate rehabilitation into that setting. Because a correctional facility's mission is safety and security. Your COs, your uniformed staff want security and safety. And that has to be priority, which is a little different. And so on the other side, you have your rehabilitation folks coming in, and there needs to be an integration, and that requires discussion. That requires open conversation. That requires conflict resolution. It requires problem reconciliation that involves all stakeholders. And what I just said took up 4 of the coming slides. Next, please. All right. So the treatment team, there's many, many people on your treatment team. There needs to be. Some are vendor, some are Department of Corrections. Again, the importance of integration. Next, please. This is what we thought we were going to do way back. See how pretty that is? Shouldn't that be a simple thing to do? This is where we ended up, trial and error. Next slide, please. So far more complexity. However, it works because now we've learned. And again, that's the reason that it's so important to use System Change 101 and involve all stakeholders when introducing the program. Next, please. I think I'm going to be just about out of time in about 3 minutes. One of the biggest pieces challenges that we faced, aside from the mission and aside from belief versus science, is the fear of diversion. So we couldn't ignore diversion. We had to look at it. And what we do with diversion in Rhode Island is it is in order to make sure that safety and security is primary, is that we have team meetings with each diversion report. And so that we have security staff as well as medical staff meeting to talk about what would be best for the individual within the context of what is best for the system. It's really worked out well. Continue, please. Skip that one. I'm sorry, I didn't mean to. Okay. I talked about the challenges, and one is whenever you do anything new, there is contracting, and it's so hard to have budget flexibility. The words, I almost can't say the words, but it's really necessary to have that, because there is always going to be something that a community treatment provider is not going to anticipate as a cost, whether it's lost dock hours, whatever it might happen to be. So going in with eyes wide open is important. Next. Okay, and I think after this slide, we'll just go to the very end where I have the slides with our outcomes. So the challenges, and we really have met them now, not just in Rhode Island, but in Massachusetts. The culture integration, dealing with non-traditional costs, knowing that staffing competency needs to be, it's beyond someone understanding MAT. Individuals need to know that they are a visitor they're in someone else's home, and many of the people that live in that home aren't welcoming them. So it takes a high degree of professional and personal maturity. Patient versus inmate, systems change, and thoughtful timelines. Next, please. Okay, so these are our metrics. Medicaid, stop at this one, I think. Here we have this right here. Good, thank you. So I wanted you to see what our inductions look like at the Rhode Island Department of Corrections. So We have new inductions. You can see that there. And in the red and the blue is the pre-release induction that I talked to you about. So if you look back to this, like the left-hand side of the graph, you see far much more blue than you see at the right side of the graph. And that's because those that are sentenced are now, since 2016, are now receiving medication, and they're receiving it for up to 4 years. So we don't have as many people getting released and asking to get stabilized on medicine because they already are. So this is really an exciting slide for me. Okay, next, please. And next, you can reference these. They're all basically saying the same thing. And next, we'll go to where we're almost at the end now. So we have, this is very important too, right? Right now, earlier we had a higher percentage. I think things are evening out, but this program in a very short period of time has shown a 39% decreased in risk of overdose death, 39%. When we first started out, it looked like something like 61 to 60. Again, things are starting to even out now. But even then, I mean, how many times in medicine do we see in introducing a new medical program that kind of decrease in risk? You just don't see these results. It's amazing. Next, please. I would like to have billboards of that, actually. The other piece that's really important is our engagement in treatment, because we know what's the point of putting all this together and having someone and having an individual start their healing process and be very entrenched in their recovery and have them leave and not be able to continue. Next slide, please. So I think what is most important before we get to this slide is to know that we have a retain in treatment, re-engagement in treatment, and then retained rate of 78% right now. And it's measured at 7 days, 30 days, and then we're measuring at 90 days, 78%. And the 22 that's not represented there are the ones that come in and go out, like they're pre-trial, they're in 2 days, they're in 3 days. So that's the population that moving forward, we're currently looking at engaging, like grabbing them while we can. And next slide, please. Okay. Next slide. Again, next slide. We'll just go through these and get to the end if you don't mind. This you can certainly reference on your own. It just tells about the process, and it was measured by Brown. This is cool. Security enhancements, they now like us. When I'm doing this for an hour and a half, I have 4 videos in here, and it's mostly security staff, but this is what our security is telling us since 2016. The environment is cleaner, makes really good sense. Less violence and erratic behavior, less conveyance of contraband, because people used to try to bring opioid medication in so they wouldn't be in withdrawal when they were arrested. Less disciplinary infractions because there's less coercion for people to give up their medication. So it ends up being safer for all staff. This is a huge, huge piece if you are in the position of trying to sell the program to your local community correctional systems. Next, please. Okay, next and next. Yeah. This cracks me up. Our wardens in Rhode Island did this so they could speak to the correctional officers. There were 22 diversion incidences, 22 doses out of 126,610. It's not a very big percentage. So next, please. And this was just what happened with COVID. I think you saw, there was a decrease like everywhere, and we're coming back up now to, I think we're only 22% away from recovery in both states. Next, please. Patient feedback survey, you can look at that yourself as well. There's 3 more of those, Angelina, if you'd like to continue through there. We learned a great deal from them, and we made serious changes everywhere from the problems that we were having in reentry to the time of dosing within the prison, within the correctional facility. We have made, it's really important to get stakeholder feedback. We have changed the program significantly and for the better. Takeaway, decrease in mortality, huge, you saw that. People aren't dying as fast when they come back into the community. Lives are being saved. Significant decrease in recidivism. I think nationwide recidivism is at about average 68%, and in our which it was in Rhode Island, our population now is showing a recidivism rate in 3 years of 41%. So it's down 30%. I like to conjecture that the reason it's down is because people are in care since the charges were drug related. 75% follow-up in the community. Okay, next. And this is just a quote from somebody named Jess Elliott, who was so smart in noticing that being incarcerated used to be a barrier to recovery, and now it is the intervention. Next. Please, any questions at all? I know that I took an hour and a half and made it 20 minutes. So any questions at all, feel free to reach out. We do it and we're happy to respond. Thank you.
And thank you, Linda. That was excellent, as expected. I've had the opportunity to hear Linda present before. I find these presentations, frankly, to be extremely interesting and to me exciting. As I said to you in my own introduction, we've been working on this for 20 years, since I wrote that article for American Jails Magazine. As Paul knows, I used a Robert Wood Johnson Innovators Award grant for this specific issue years ago to really focus this information, focus this sort of visionary approach. From my point of view, and I don't want to run the risk of being overly elegant, but to say that to provide access to treatment is really something that is a constitutional right for the patient, and Paul went through that. This is part of in the United Nations publications and the WHO, World Health Organization publications, and their guidelines that basically says this is the right of the human being. And they basically frame it as a human's rights issue. So I want to be able to answer the questions that have come to both of you. I'll start with a question to Paul, then go to Linda, back to Paul. We have a few minutes, but I want to respond to them. And obviously everybody who's participated in this webinar is going to get access to all of these remarkable slides that were shown. So for Paul, we're seeing some egregious examples of people being denied access to MOUD while in the criminal justice system. Are there strategies that peers and SUD providers might utilize to help get individuals such life-saving medication they need in the community?
So the answer to that is yes. It's a great question because we're all of us who are working with these folks are in a position to try to move our public policies forward, but especially to get people help. And now, as we've talked about today, there's a huge amount of evidence about the efficacy of this care. There's also a legal basis now to require it. So providers, peers, anybody working with people who are in need of care can weigh in. And they can do that in a variety of ways. They can reach out to, if there's legal assistance in the community, they can reach out to that. They can contact us at Legal Action Center because there's really opportunities now to try to really push this forward. And with the law behind us, we are finding increasingly that there are local attorneys who are willing to represent people. We're happy to act as a resource directly to people who have a problem, but also to attorneys who may be helping them. And then there are also government agencies that oversee law enforcement that deal with substance use disorders, that also could be useful in intervening. State or federal agencies. Now the Department of Justice, as I talked about, is interested in this. So we're urging everybody, if you see a problem, to make a complaint to the Department of Justice, as well as to state and local human rights and civil rights agencies.
And I can tell you, since I'm at the offices, what we join with the Legal Action Center in New York, what Paul just mentioned is something that happens with some frequency, where the attorneys, the team at the Legal Action Center, advises the local attorneys and gives them access to the resources that the Legal Action Center has accumulated over the years. So it's a very important function. The question now is to Linda, and boy, this has come up to me many times in my discussions, which is the issue of how do you manage a methadone patient who is incarcerated, and then when they're released, but they are paroled to a county where methadone is not available?
That is a question. And we don't have that issue actually in Rhode Island. We're a small state. And but we are facing it in Western Mass, where resources are very sparse. And what we do as a system, and what I would suggest any kind of correctional entity would include as a deliverable in their contract with a vendor, is we assure that we will provide an individual with care until they can get connected to the provider of their choice. So at discharge, say someone's mother lives 100 miles away and that's where they need to go. We start to look at, okay, you've been utilizing methadone, there's no methadone available, there's no vans, there's no nothing we can do. So would you like to try another medication? And we can begin that medication and it can be prescribed to you. It may not be optimum, but that's an example. So that if you take these cases on a case-by-case basis, there is a way to assist individuals in getting them back into the community and getting what they need in recovery. The problem with methadone is just what you said. There's really not much we can do without mobile units, or without, frankly, a more financially feasible way to have satellite offices.
Well, and this is also what I talked about in my introductory remarks.
Yeah.
This is why we're trying to expand the footprint of the OTPs. And one way to do it is with these vans. Another way to do it is with these satellite medication units, but again, tying into the OTP as the centralized hub site. So this is really an issue that gets to systemic reality. And I completely understand the question, because this comes to me from correctional managers and sheriffs. How do we induct a person with methadone if there's no OTP to refer them to? And Linda's already responded to the issue of medication flexibility. Now, to get answers to a few questions, we may go beyond by 5 minutes or so. So bear with us as well. And there's a question to Paul. And the question here is from Kathleen. How is this being handled in terms of advocacy treatment for federal prisons? In Vermont, people have access at state prisons, but if they have to go to a federal prison, my understanding is they are unable to access MAT treatment.
Yeah, it's a real concern. As I talked about earlier in my presentation, there have been 3 successful cases now brought against the Federal Bureau of Prisons. So we are a little bit more optimistic that they may finally start to react in a better way. So I think that the answer is to keep the pressure up. Whenever there's somebody who's in a federal prison who needs MOUD and is not getting it, then we all need to try to take action and press that. That's a perfect example of bringing that to the U.S. Department of Justice, since that's where the Federal Bureau of Prisons lives in the government structure. But also feel free to contact us at Legal Action Center and/or to try to get in touch with local attorneys to try to make sure that people's rights to the life-saving care they need are guaranteed.
And this question is now for Linda from Stephen, and it goes to the point of research has not been able to determine which of these 3 FDA-approved medications is best. It seems there is some pushback against Vivitrol. I've seen success in all 3 types. Is Vivitrol a hot potato, so to speak?
I think this is, again, now we're getting into a little bit more subjective area. I agree 100% that everyone is different and every individual is going to respond differently. Again, I said about 80% of the time we see, as I described with those pictures, one medication probably works better than another. Many of us have physical responses to the medicines that would say, I'm simply not going to be able to handle that one very well. But Vivitrol, if you will, being a blocker, works beautifully for craving. I've seen it work beautifully for those in recovery that were worried about craving. They had different kinds of brain change responses. So I think all 3 medications are great for what, they're great for individuals. I don't think, I'm pretty agnostic. Like I said, I'm pretty agnostic about the medicines. I think the pushback on Vivitrol right now may actually be emotional because of everything that was attached to it in the strong sales to the jails a few years back, and then the community responses to that. So there's some political pieces, some emotional pieces, but from a science perspective, whatever medicine works and that the patient will take is fine by me.
Right. And I think Linda's point is well made. From our point of view, frankly, the issue is not the issue of provider bias per se. The issue is what is the medication that works best for the patient at a particular point in time. And this is a complex illness. So technically speaking, a patient may benefit from one medication at a point in time and have a different reaction later on. Yeah. And so while some patients prefer methadone maintenance or buprenorphine, typically the patient that has a preference typically is based on the last successful medication intervention. So if a patient has had a good experience with a particular medication, that would be the medication of choice. This is fairly common sense. And then if a person had a negative reaction to a medication, whether it's methadone, buprenorphine, or Vivitrol, then they're not going to want that medication. And who would? None of us would, frankly, if we're going to our physicians and he says, oh, she says, by the way, this is my recommendation. And the patient says, yeah, I tried that. It didn't work. What person who's reasonably sane will say to the doctor, no, but give it to me again. Let's see what happens. So you have to understand the nature of this. Last question.
Mark, if I could just weigh in just quickly, say also that from a legal perspective, from our view, it really mirrors the policy priorities that Linda and you both just said, which is that patients should have a legal right, not just a healthcare right, but a legal right to whatever medication they want and is best for them, regardless of what that medication is, if it's an approved medication.
And there is, in the end there where I went pretty quickly through the slides, you'll find that there are 3 slides that show medication changes and why individuals have said, I don't like this, I want that. And I think that gives a nice insight. It's a good example of what Mark just said.
And so this last question is going to go to you, Linda, so we can close out. And this comes from Cassandra. Many of my patients who attend MAT after incarceration have difficulty with medical attention and employment. With utilizing Medicaid 30 days before release, will this possibility be part of a continuing program to decrease the recidivism rate? And then what happens with those persons once they have been discharged to prevent relapse?
Okay, in the model that I described to you, we have someone in place in the prison to start the application for Medicaid prior to release. we never know what's going to happen when somebody gets out. I think that's the way it is in many states. It could be 30 minutes, it could be 40 days. And what we have found in Rhode Island, and we are finding in Massachusetts, is that we go ahead and provide care for individuals in the community. If Linda's getting out of prison and our discharge planner says, I called your doc and your doc said, say it's buprenorphine, your doc said, oh, I'm so glad Linda's getting out. I'll see her in 3 weeks, right? So what happens to Linda in 3 weeks? Does she get her Medicaid in time, number one? And number two, who's going to see her for the 3 weeks? So one of our deliverables is we continue to provide care, even though someone doesn't have active Medicaid, because in Rhode Island and Massachusetts, you can retroact bill. Since we've been doing this, we've only had 5 episodes of unpaid treatment, only 5 out of thousands. So I think there's a bit of a mythology around Medicaid and that gap. But it really it changes state by state. So I can only speak to the 2 that, within which we're working.
Okay. All right. There are several other questions that we did not have time to respond to. For those individuals, we have your questions. I will refer them to both Paul and Linda as appropriate, and they will respond to you because, as you can imagine, they are responsive people. But I do want to hold as close as we can to our time frame. I know that these webinars may seem lengthy, but I'm grateful to both of our speakers, Paul Samuels and Linda Hurley. As you can get from both of them, this is a huge amount of information to try to truncate into brief presentations because it's enormous, and they both have resources. So I advise you all, if you have an interest, look through the information that Linda presented, and she said they are reference points, and the same for Paul. You have access to all of this information. And I can tell you, given my long-standing interest in this, I see more information, much more work on this in the last several years than I've seen for the past 17 to 25. And that's a truth. And the resistance that I once experienced in talking with administrators, correctional facility managers was, why do we have to provide access to medication? Why should we solve society's problems if they couldn't solve them on the outside? And the answer is an obvious one, because you have, for lack of a better way of putting this, a captive audience. And because you have such a captive audience, I think there is an incumbent responsibility to do what you can. And based on all the information you've just been exposed to in the past hour, it makes the case, in my judgment. But I understand none of this is intuitively clear. You have to explain it, then you have to re-explain it, and you have to have a lot of fortitude for this. There is no simple single solution. And knowing both of these people, as I do, they would understand that and they would certainly reinforce it. So, in conclusion, I'm grateful for our presenters. I think they did a great job in giving you a lot of information. We will respond to questions as I ferret them out to them. I'm grateful to Mallinckrodt for their willingness to support us in this criminal justice system grant, because it's reaching out to people. It is one of AATOD's major policy initiatives, and we're going to be following this for years to come. From my perspective, we're taking every advantage of the opportunities given to us. I've learned through my 40-year career, don't pass up on an opportunity because you'll lose your ability to reach the people you need to. One of our profound realities is we expand access to treatment for those in need, and we do it through every environment we possibly can. Right now, the focus is on criminal justice. We're going to have more success in the future. So I encourage you to follow this, to implement this. My desire is to see treatment programs throughout the United States work with correctional facilities so we can bring in tens of thousands of patients, think of it, out of the jails, out of corrections, into treatment where, frankly, they more properly belong. That's just a reality from my standpoint. So with that, I thank Angelina also for her help in coordinating all of this, setting all of this up, and we will continue to offer these webinars to you. Thank you again. I hope you enjoyed this and have a great day. And remember, there's a survey after this, so please do take the survey because it guides us in the future offerings that we will do. So thanks again, be well, and have an excellent day.
Thanks, Mark.
Thanks, Mark.